Yeah, but anyway, okay, we're live. We're live
Yay!
with Dr. Andrea Salcedo, and this is our second try because last night in South Africa, or yesterday afternoon, on the west coast of the US, we tried this, right?
We tried.
We
Yes.
tried,
Yes.
and Dr. Salcedo got called into an emergency surgery 2 minutes into the live, and I did such a beautiful introduction, didn't
You
I?
did. It was so
I
good.
did.
I'm like, I can't believe we have to stop, so it was really great. So
Oh, well, thank you. I'm going to try again. If everybody can give me 2 minutes, I'm going to reintroduce everything because I don't know who was there and who wasn't there. I also didn't get, I saw the Tia Reed, the most amazing, nutrition network practitioner from one of the coaching pathways. She was there, and I didn't even say hi, Tia, but I appreciated her being there because I was still in the midst of my intro, and then I felt all thrown. But it was really good to see Tia there. So if anyone does want to drop a message, I will read it. Maybe not during the intro, but I will read it. Dr. Salcedo will read it. We'll answer questions because we want this to be interactive as well. But before I go off on a tangent, let me introduce what we're doing here, what this live, and which will become a YouTube video and a podcast, is all about. And then let me introduce the amazing gynecologist we have with us tonight and her awesome, groundbreaking study, which really challenges some major beliefs around abnormal uterine bleeding. So any of you out there who have abnormal uterine bleeding or who know someone who has it, and I cannot tell you how many women can identify with that. So I'm sure if you're a man, you've got a sister or an auntie or a mother or a wife or someone who has abnormal uterine bleeding, and there's something behind it that we didn't think was behind it, right, Dr. Salcedo?
yes.
So that is what this is all about today, is to discuss that. So I'm going to just start with my introduction again. Here we go. And if you guys want to drop hellos into the chat, please do. So this is our Nutrition Network Live, everybody. And for those of you who don't know me, I am Tamsin Murphy, registered dietitian and head of content here at Nutrition Network. So we're really, really glad to have you here today. And as I said before, you might be watching it live now, but you can also catch the replay, and it will also be on our YouTube channel and on and also on our new podcast, which is very exciting. And these sessions that we do here are all about bringing you cutting-edge insights from the world's leading experts, such as Dr. Salcedo, who are experts in metabolic health, nutrition science, and therapeutic carbohydrate restriction. And here we want to translate science into practical clinical tools that you can use. So this is practical. Yes, we will be looking into Dr. Salcedo's study and discussing what she found, but also what are the implications? There are some serious implications and things that you can do about it to improve your health, your gynecological health, your overall health as well. Please feel free, as I said before, to drop your questions or comments in the chat. So let's dive into today's discussion. It's going to be a really, really good one. We had a false start yesterday, but this is going to be amazing. So let me start by telling you a little bit about Dr. Andrea Salcedo. She's a board-certified gynecologist and one of our very own medical certification path graduates, which is very exciting. I do want to say that our medical certification path has just opened for this year. If any of you are interested in being amongst these excellent metabolic health practitioners such as Dr. Salcedo, please join the medical certification path this year. And Dr. Salcedo is also a passionate advocate for metabolic health in women's medicine. And she's here to share insights into her groundbreaking new publication that just dropped last week, titled The Uterus as an End Organ. We'll be getting into what that means. A preliminary study of insulin resistance and abnormal uterine bleeding. And it was published in a leading journal in the field of women's health called Menopause. The study takes a bold step towards reframing how we understand abnormal uterine bleeding, not simply as a hormonal issue, but as a potential signal of underlying insulin resistance. And that's a perspective that really could fundamentally shift how we approach everything from menorrhagia, which is unusually heavy or prolonged bleeding, polycystic ovarian syndrome, perimenopause, you name it. Dr. Salcido, second time lucky. Welcome.
Yes, that was amazing. That was very, very good. That was so great. I'm so happy to be here. And really, I couldn't do any of this without the Nutrition Network. I can't tell you how instrumental that organization has been in my whole life. And I'm just looking forward to seeing you guys in October. And just, I don't know, I think it's just such a dream of mine to be with such incredible leaders in the field, thinkers, people who are interested in thinking outside the box, evidence-based medicine that is looking at what we know as health in a different way. And so I just can't tell you how much I really care and appreciate and love you guys and what you're doing. And so you got a fan over here in Southern California.
Well, we're your hugest fan too, our own conscious gynae. And I'm so looking forward to meeting you for the second time in October at the World Nutrition Summit held in Cape Town. So if any of you want to meet Dr. Salcido in person, that's the place to be, Cape Town, South Africa in October at the World Nutrition Summit. And she will be speaking about all of this stuff. I know that so many women have got so many questions for you. So if you can't get it in now, get it in October. All right.
That's right. I'm also going to be in Tennessee in September at Low Carb for Better Life with Dr. Barry. So if any of you guys in North America, it's a little closer than South Africa, but yeah, awesome. I'll also be there too. So just excited to meet everyone and talk about the study. So thank you, Tamsin.
Awesome. Well, let's get into it, shall we? So I think what I want to start with is like what your title says, what it means. So, reframing the uterus is not just reproductive, as we obviously think about the uterus, the womb, it's reproductive. That's where the baby grows, but it's also metabolic. Like that's a bit of a, I don't know, mind shift moment, right? But let's start with what it means to call the uterus an end organ.
Very good. Great question. So in healthcare practice, we often talk about the end organ disease, and end organ disease that the body's organ receive from cardiovascular disease risk factors that folks carry as they're living life, as they're exposed to different triggers and inflammatory factors. So some of them could be like smoking, some of them could be carbohydrates or stress, and so there's all of these like different risk factors that can actually send molecules of inflammation all over the body and can lead to organ damage as we know it to be, is heart disease, asthma, it could be kidney disease, all of these diseases that are related to some bigger problem is what we call end organ damage. Okay. So the uterus is also an end organ. It's an organ at the end of the circulation, just like all the other organs are at the end of the circulation that receive inflammatory factors, just like any other organ. Well, the interesting thing is that the uterus is made of something called smooth muscle. And so the uterus is actually considered like one big blood vessel because it is made of this special cells called smooth muscle cells that are the same cells that are found in our circulatory system, our arteries. And so when the arteries receive inflammation, we see that manifest as atherosclerosis and hardening of the arteries. Well, the uterus receives that same inflammation both at the corpus level, which is like the body of the uterus, but also at the lining of the uterus. Okay, so the body of the uterus, we can see that as manifest as something called uterine fibroids. And uterine fibroids are made of the same, what we call fancy word, progenitor myocytes. Okay, the same muscle cells that are seen in atherosclerotic disease. And so that's pretty mind-blowing. So I often tell and teach my resident doctors in training and medical students that uterine fibroids are basically cardiovascular disease of the uterus. That's kind of fun to say. And but then if our body can manifest these problems in different ways depending on what our body type is like, but some people don't have fibroids. Some people just have heavy periods. And the reason why is because, well, the lining of the uterus is filled with blood vessels. And so if our blood vessels at the lining of the uterus are receiving inflammatory factors, then those little tiny microscopic blood vessels don't function as well as any other blood vessel. And so when the lining of the uterus sloughs off, then the vascular bed of the uterus that is there to stop bleeding, those little blood vessels don't constrict as well and stop bleeding as fast or in an amount of time as they should. And so that's where people start to get these long, prolonged, heavy periods because the little blood vessels don't constrict as well. And so here's the funny thing is that, did you know that we're only supposed to bleed about 30 to 60 milliliters per period, which is the corollary is like, that's equal to two shot glasses of alcohol, right? And so like it's this little thing, and we're only supposed to bleed 2 to 3 per cycle. But I mean, now, in the United States, we have like period underwear because people are like bleeding through like their pads and they're flooding and stuff. And so, really, I think we have started to accept that heavy periods are just something a woman has to go through, a rite of passage, a little bit of silent suffering, but it really shouldn't be that way. It really should be that we legitimize this heavy period as perhaps a metabolic problem, perhaps that our body's receiving inflammation that had been there for a long time. And this is just how it manifests in women. So that's the whole nidus for the study.
Wow, there is so much there. Firstly, I've never heard of the uterus kind of described as almost like a blood vessel, really. And as soon as you do that, then you're like, okay, well, all these things that go on in the blood vessels that cause heart attacks, strokes, all this like peripheral vascular disease or whatever might be happening in diabetics, for example, all those things that you think of like blood vessel disease, cardiovascular disease, it is the same for the uterus. That is a huge aha moment for me. And I'm sure it is for so many other people. And then as soon as you say that, it's like, okay, well, fibroids, abnormal uterine bleeding, it makes sense. It makes sense. Inflammation and whatever's causing that, which then affects the uterus at the end of this kind of dysfunction, it makes so much more sense. I'm surprised that I haven't heard this before, Oh, wow.
I know. I feel the same. I went through, medical school, residency, OBGYN residency, several years of practice. No one was talking about this. And I thought, how is it that we're not making these connections? And actually, when I went into like the deep dive of the literature, actually, and the basis of the study, the introduction, I was pulling studies from like the 60s to like legitimize the pathology, because at that point in time, people were really looking at cells under the microscope and trying to figure out what uterine fibroids were all about. And so we've actually known this, that uterine fibroids come from the same progenitor myocytes as atherosclerotic disease since the 1960s. Wow. But the thing is that like we're really good at medications and surgery, right? Like as gynecologists, like, because think about it, like by the time you get to see the gynecologist, like you're just so over bleeding, and you're so sick of your painful periods, or you're the pressure of the uterine fibroids or endometrial polyps or whatever, that you just want solutions, right? But I just, and believe me, medications and surgery, that there's a role for that for sure, but could it be that the first sign of these heavy periods or PCOS brings us and lends to a discussion of how we got there, right? And more of a discussion of prevention and understanding the impacts of all these inflammatory factors on a woman's body, and how it manifests. So then it really changes the narrative of the discussion, right? It's not
Yeah.
like go see the gynecologist for your female hormone problems. It's actually not mediated by that at all, you know? It's
No.
actually mediated by insulin and inflammatory factors. And
Wow.
so
So
it's
so
just
let's so I'm going to interrupt you there because I
yeah,
think
yeah, yeah.
we're getting into the nitty-gritty there, and I'm not
I
quite
know.
ready because I have two
Yeah,
more
I know.
questions.
Okay, okay.
Before we get into those inflammatory mediators and insulin resistance, it's all behind it. Firstly, some women will know that they have very heavy bleeding. If they have, a huge amount of pain or very prolonged periods, or they've been diagnosed with something like fibroids or endometriosis or something, right? They've been diagnosed with something. But what about the women who are like, well, I don't know what normal is, because as you said, we're now getting to the point where it's almost normal to have heavy bleeds, right? So you've explained it in like shot glasses, but very few women measure their period that way. So how would you say most women would be able to know if their menstruation or period is excessively heavy, firstly?
So a normal menstrual cycle should last 3 to 5 days, right? That's wow. I even hesitate to say that because so many women, that's not their norm. And so also another sign of heavy menstrual bleeding is that if you are changing your sanitary pad every hour, that's not normal. Um, I don't want to say that like the presence of clots is a negative thing because a lot of times when women are sitting and they're on their period and then the blood kind of collects in the vaginal canal and then you get up and then you get like a clot that comes out of your vagina. Everyone kind of knows that feeling, and so it just means that your body's doing what it should, and it's a little blood clot happened. But truly, if you're changing your pad more than once an hour and your period's lasting more than 5 days of heavy bleeding, that's
Mm.
not normal, okay? That's actually not normal, and so 7 days of a menstrual cycle is actually on the or on the starting to be abnormal kind of thing. Um, like some people are like, well, I have heavy bleeds for like 5 days, but then on day 6, 7, it's just spotting. Well, that's okay. But
Mm.
I would argue I have plenty of patients that once they start doing some interventions, like it gets much lower, it gets a lot shorter. So, and if you
Wow.
think of the physiology of the menstrual cycle, the lining sheds, that's usually like day 1, and you experience a lot of cramping and stuff. And the lining shed, once the lining sheds, on day 2 is usually when people start noticing like the real heavy bleeding. And that's because those blood vessels are raw and exposed. And that's the time that they're supposed to do what they're supposed to do and like, start to constrict so that you don't have long, heavy bleeding. And
Mm.
so, yeah.
Okay, so now we know. I just wanted to make sure everyone was on the same page because, you know, I don't really know either. I know that, it's if we're what 4 days, 5 days is what I've heard, but we don't really talk about this stuff much either.
Yeah.
So I think it's really good to just make sure we're all on the same page with what this means and what it looks like, before we moved on. The second thing is, you mentioned that now that we know that abnormal uterine bleeding isn't just a hormonal, well, isn't a sex hormone issue alone necessarily. Let me put it
Good,
that
good,
way.
good, good, good.
Um, um, does this change the way clinicians now must approach menstrual disorders? It feels like it must do, right?
Yes, it absolutely does. I think that the American College of OBGYNs does recommend that we check fasting insulin levels in women who we're suspicious for PCOS,
Mhm.
polycystic ovary syndrome. And PCOS, which many of us in this space kind of know, is the syndrome of irregular periods, hair or acne where you don't want it, and tiny, tiny cysts on the ovaries. And it is kind of first phase pre-diabetes, in my opinion, for women. And when we have that, they say, okay, start checking the fasting insulin level to see because high insulin levels will start to block ovulation. And so that makes sense. But PCOS is kind of like something a lot of women deal with in their reproductive years, or people are talking about it in their early reproductive years, 20s, 30s. But once you start getting a little bit older, late 30s or 40s, then I believe that the chronic inflammation that led to PCOS then starts to manifest in other ways, because the inflammation didn't really go away, because you just got older or because you're out of normal childbearing years. It just turned into something different. And so, yes, it does lend to continuing to encourage healthcare providers to consider a fasting insulin level in women, particularly obese women, to help them understand what level of inflammation is really happening.
Okay. Well, I think you've mentioned, now we got to dive into this. Now we absolutely have to, because you mentioned insulin resistance, you've mentioned obesity, and these are things that, those are the main findings in your study, right?
Right.
So maybe tell us about those main findings, and then maybe we can talk a little bit around, like, is it just obesity? Is it just because these women are obese? Or is it the insulin resistance that comes first? Is there like some kind of relationship? So maybe let's go there. Let's look at what's behind this. Walk us through it.
Yeah, so this study was a cross-sectional study. So it was purely exploratory to see if there was any kind of association. And it actually stemmed from an initial cross-sectional study I published a few years ago in the Journal of Insulin Resistance that looked at what is the prevalence of insulin resistance in women who have abnormal uterine bleeding. And that study found a prevalence of about 66 to 70% of women in that. And that is huge. And so then, that was just women who had abnormal uterine bleeding. So then I said, well, let's turn this into a cross-sectional study where we look at women who have abnormal bleeding and women who have normal menstrual cycles, and let's compare them. What happened was, believe it or not, finding women who actually have normal periods is really hard to do, okay? Because many women are on birth control methods or hormonal birth control methods and stuff. And so to actually find a woman, it actually took several years. And unfortunately, the data was gathered during the pandemic. And so it was really hard to even get people to the clinic. And then to find them when they were normally menstruating was really challenging. So we got these two groups, and then we started comparing them. And so I only relied on women who just asserted that their period was normal. Like, we didn't do anything. We didn't do pad checks. We didn't do like hemostains or anything like that to measure. They just said that what their thought of what normal was, okay? And we compared them to women who really did have abnormal uterine bleeding with real risk factors and real evidence of that. When we compared the two, we looked at specifically insulin, okay? A lot of studies look at HOMA-IR and hemoglobin A1C and all these very interesting ratios. I just wanted to look at insulin because I just felt like it was something undervalued in this space. And I looked at women who were all causes of abnormal uterine bleeding, other than like being on a blood thinner because a doctor put them on them because they had a thrombus or something. So non-iatrogenic, which means like not induced by medical intervention, non-iatrogenic, benign causes of abnormal uterine bleeding as a whole. Because I mentioned that we know that high insulin levels are associated with women with PCOS. That's very well established. When I looked at all of them, we saw a 3 times risk elevation for abnormal uterine bleeding if your fasting insulin was above 10.
Wow.
Excuse me. Hold on, I've got that little cough. 1 second, guys.
No problem. Wow. So 3 times higher, your risk is 3 times higher if you have an insulin of above 10. So that already tells us that there's something that either you as a patient can do or you as a doctor can do, which is check for insulin. If fasting insulin is above 10 millimoles per liter, I imagine, then then you've got to address it, because that could be behind, or playing a role at least, in the abnormal uterine bleeding that you're seeing.
So as a whole, so we looked at that when we removed all the confounders, so hypertension and obesity and things like that. There was that 3 times elevated risk. When we allowed for the confounders, the risk diminished, particularly with obesity. Now, that's very interesting because we know that there is some sort of collinearity between those two. We know that insulin and obesity are very intimately related. And so the risk became non-significant when we added the obesity to that analysis. However, when you remove it, it's there. Okay, so what does that mean? That means that those two markers together work together codependently. They don't work together just on their own. And we know that. We know that. Now, I think it's very interesting because when you get deep into this space of hyperinsulinemia and insulin resistance, we know that bodies manifest inflammation very differently. Some people in gynecology, we talk about them as the thin PCOS person. And that person tends to have a little bit more acne. They're more slender. They tend to have more organ manifestations, more of the ovaries with the small cysts. Their periods are a little bit more irregular. Women who are the obese PCOS tend to continue to have irregular periods as well, but they don't have a lot of the acne or other manifestations, the hair where they don't want it, like we see it with the slender people. Now, what's that about? Well, then it kind of may lend to those concepts of diobesogenic phenotypes in diabetes and obesogenic phenotypes in just obesity syndrome as a whole. So we call them the diobesogenics, we call them the energy thrifty people. So in that group, we see that their insulin levels aren't that high in the thinner people. Okay. And so you like look at someone, you're like, I swear you have PCOS, or I swear that you have insulin resistance. But then their insulin level is like 3 or 5 or like something really low, but their hemoglobin A1C is 6. And so, and you're like, well, what's up with that? Right. Well, I believe, and this is like my new ideas for future studies, is that in the diobesogenic folks, maybe their insulin isn't working as well for some reason, or their pancreas isn't secreting well that insulin for some reason. And so then their glucose level is higher, and then they tend to store that excess glucose in their abdominal adiposity, in their yellow fat around their organs. We know that people who are more obesogenic have high insulin levels, and their hemoglobin A1C is like really low, like 4.9 or 4.7. Well, why? Well, because their body's really good at storing energy. Okay. And so then it stores into their periphery instead of that abdominal adiposity. They have it too, but they have more of that storage. And so that's where a lot of like ketogenic diet works really well for a lot of these people, because they just drop all the weight because they're just really reducing their insulin levels. In the thinner PCOS patient, the ketogenic diet or low therapeutic carbohydrate restriction works really well actually for them, because their insulin doesn't work as well, it seems, to store the glucose. And so then they have less of that circulating inflammatory high glucose levels that can impact their organs. So I know we're kind of getting in the nitty gritty, but I think that's what we're seeing here, is that collinearity of insulin and obesity working together in high insulin levels, causing, or what we see as associated with abnormal uterine bleeding. I really kind of want to do the study that looks at how does insulin manifest in all of these different classifications of women and their phenotypic or like external expression of what metabolic disease looks like to them. So that's
Wow.
all ongoing, right?
Well, it's fascinating because the thing is, whether you have high insulin, and insulin is a fat storage hormone, so you have high insulin, it puts you into fat storage mode, you gain fat, but your blood glucose is lower. So your HbA1c is a test of your blood glucose over 3 months. That's lower. Whether you're sure, whether it's that way or your insulin is lower and your blood glucose is higher and you're skinnier, either way, it's going to help to lower your carbohydrate intake, either to lower your insulin and help you lose weight, or to basically allow your insulin that you do have to work and put less load on that insulin because it's not very high. So either way, it's helping, which I think is really, really interesting. Yeah, so maybe I think before we get more into the ketogenic diet, I wanted to just ask whether you have an idea of what is actually happening, like physiologically, between high insulin and the endometrium. Is it the inflammation associated with high insulin? So could we actually just be testing, for example, I don't know, C-reactive protein rather than insulin? Because if inflammation is what's causing the normal uterine bleeding, what insulin seems to be one step away. Or is there some kind of more direct pathophysiology going on between insulin and the endometrium?
Yeah, I don't know. I think it's multifaceted. I think it's not just insulin. And I check C-reactive protein on a lot of my patients, and a lot of times it's normal. But remember, C-reactive protein comes from the liver, right? And so that means that the liver is already seeing the reaction, okay, from the insults that the body is receiving. So whatever it is, C-reactive protein is just a manifestation of the insulin or the inflammation that has already occurred. So, and inflammation could be anything, and it could be your immune system being activated. It could be the insulin, it could be the glucose, but all of those inflammatory metabolites are impacting the smooth muscle and damaging the smooth muscle. And if we think about, I think of, oh gosh, what's that? My favorite, like Irish bioengineer. What's his name?
Ivor Cummins.
Ivor Cummins, and he talks about that glycocalyx, right? And he talks about the damage that hyperglycemia does to that glycocalyx within the blood vessels. Well, yeah, and so of course the blood vessels in the lining of the uterus, right?
Yeah.
And so I think that's what we're talking about here, is that it's not just one thing, and it manifests in different ways in different people depending on their phenotypic expression. And so I think that C-reactive protein is helpful, but I wonder if it's even way before that. And there's no marker to measure, right? Just like, that's like what we're all scratching our head about, is that maybe insulin is just one of the markers, but it's not the whole picture, which is what the study also shows. So.
Well, that's the thing. The study shows that it's also the obesity. It's more this metabolic profile, right? Is that insulin is a proxy for this metabolic profile, metabolic dysfunction. So do you think then, Dr. Salcido, whether doctors and, I don't know, lay people should be looking at menstrual irregularities as early warning signs of metabolic dysfunction? So not only are they now trying to correct their irritating, painful, prolonged bleeds, but they're actually saying, okay, when I bleed irregularly, too heavily, too long, too painfully, is it showing me that something's off metabolically? Is that logical? Can one?
Oh, it's totally logical. Yes. I think I even did a lecture for a Nutrition Network that calls the menstrual cycle is a vital sign. I can glean so much information by asking women, does your period come every month and how heavy is it? If you can tell me, I can learn so much about your metabolic health by those two questions. And I think now we understand why. Is your period regular? Well, that comes from as long as it's not like a thyroid or a prolactin problem. If your period's regular, that means your insulin level is low enough so that it's not inhibiting the ovulatory factors that will allow a woman to have a baby, right? So that's the regularity piece. And is it heavy? Well, it's the inflammation piece, right? So it's the endocrinologic piece and the inflammatory piece that tells me everything from a woman's menstrual cycle. It is the vital sign for women.
Wow. Well, that is a huge. I just want everyone to just sit back and listen to what Dr. Salcido just said. It is the vital sign for women. So, I mean, quite literally the red flag, right? For women. So, yeah, just think about that, ladies, and start taking it more seriously. But now what's been cropped up in my head twice while we've been talking, the first time it disappeared, but now I'm not going to let it disappear, is the use of oral contraceptives. Surely that's going to now make people regular, and potentially hide metabolic abnormalities, or does that regularity that they get from the pill make you more metabolically healthy? What are the implications of artificially regulating your menstrual cycle? I think that's my question.
Yeah. And so here's the thing is like I'm a full scope OBGYN, so I do a lot of lifestyle and metabolic discussion. I talk about medications, I talk about surgery because not everybody is in a place in their life where they can completely change their diet or whatever. And so it's inherent upon a full scope practitioner to have an understanding about all three options. So that being said, if a woman is bleeding heavily, gosh, like, and it's impacting their life, they're like flooding through their clothes and whatever. Yes, the discussion should be towards help, and medications and surgery are very helpful in that. Combined hormonal contraceptives, which includes pills, patches, rings, all those kinds of things, are estrogen and progestins that basically protect the lining of the uterus so that once you're not on them for that week, so usually they come in formularies of like 3 weeks of pills or patch or ring, and then a withdrawal week when you're not on them. And that induces the quote unquote period, but it's not an ovulatory period. It's just the withdrawal bleed of the hormones because you're not on them that week. And so the lining of the uterus like sheds. That sometimes really brings about so much regularity and predictability to a woman's life. Not only does it also protect against pregnancy, right? But that is sometimes what people need to bring themselves back to normal bleeding, not anemic, not needing blood transfusions and stuff. Just like anything, though, it comes with risk, right? Everything comes with risks and benefits. And so some of those risks can be, a little higher risk of a blood clot or a thrombus, hypertension, sometimes elevations in triglycerides. Rarely it's associated with different cancers like breast cancer. And so those kinds of things are important. But, we know that a lot of lifestyle factors also increase those risks too, way more than the birth control patches or pills would do. But it's still important to know about. They do also prevent against some cancers. So they prevent against ovarian cancer because women aren't ovulating, and there's a suspicion that ovarian cancer comes from some sort of ovulatory process or some of the germ cells that come from the ovary, and that helps prevent that. It also protects against cancers of the lining of the uterus because when ladies are not ovulating every month, then the lining of the uterus just builds and builds and builds and builds from the what we call unopposed estrogen that the ovaries are secreting. That tends to thicken the lining of the uterus so much, then a lot of women will just have this unscheduled bleeding. But the chronic exposure of unopposed estrogen also from obesity. So our fatty tissue secretes a special hormone called estrone, and estrone also activates the lining of the uterus. And so that obesity, that chronic anovulation, all thicken the lining of the uterus. And it's like too much of a good thing. If you have too much estrogen type molecules, eventually one of those cells is going to become abnormal. And then that's where we see uterine cancer. Okay. And so if we protect the lining of the uterus with a progesterone style or progestin style medicine, that prevents against the risk of uterine cancer. Okay. Or birth controls do the same thing. And so everything has like its pluses and minuses, you know? And so, but it is not a period when people are on birth control and they have this bleed. It's actually not a period. It's just what we call a withdrawal bleed because you're not on the hormones anymore.
So it's not your red flag. You basically aren't able to, your vital sign is missing.
That's right.
Not that you're dead, but your vital sign isn't apparent. And so you can't therefore judge your health based on your period during the use of oral contraceptives or other kind of hormonal contraceptives, right?
That's right. Mm-hmm.
Okay. And now this leads me to another question around perimenopause and menopause. So does this, like, then you're get to a point where you no longer bleed, and is that also then your vital signs over? You can't judge anything on that, or is there some like abnormality around perimenopause with like how you're supposed to slowly stop your bleeding? Is there normal? Is there abnormal? Like, what's going on there? How do we judge it for women who are either perimenopausal or menopausal?
Yeah, so, the menopause transition can last about 10 years, which is a long
Oh,
time, So
10 years.
that's
I thought it was
I
like
know.
1 year.
Yeah, so the transition that your body is like, okay, we don't have as much oocytes, ovulations as we did, before. The estrogen level tends to wane and rise and wane and rise and up and down and up and down, and it's not as steady as it used to be. That being said, that's why it takes so long to kind of get there. It's not like an overnight thing. But in the years leading up to the final menstrual period, it's normal to like miss a period, every once in a while because maybe your ovulation wasn't as robust, or maybe the ovulation just didn't occur. And so, then sometimes like the subsequent menstrual cycle will be like a lot heavier too because the lining has just been building up. We know that the phase around that time is very intimately related to insulin also and metabolic health. We know that women who are more metabolically unhealthy tend to have worsening hot flashes, increased weight gain around their midsection and stuff. And that is all very much intimately related to insulin. And so a lot of women, just like even during, what we call premenstrual syndrome, the hot flashes, the irritability, some of the crying, the hopeless feelings around right before your menstrual cycle. Sometimes that comes up also during perimenopause or that right around that time of menopause. That has to do also with metabolic health as well. And so really just because your menstrual cycle, especially in menopause when you're done, or perimenopause where it might not completely apply, it is still a very important vital sign how you feel during that time because it's still very much mediated by that metabolic factors that we know about. And so, I always tell patients when they're in their perimenopause or even menopause phase that it's now is the time more than ever to really monitor those inflammatory factors, lifestyle factors and stuff, because you really do need to rely on that to help get you through those important phases of life.
Wow. So again, there's a lot there. We could talk to you for
Right?
hours.
I know.
But so what I'm hearing now, which is a little bit different from what we said before, is obviously now you're going to have irregularity. It's normal to have irregularity around the perimenopausal stage, both in expecting to have no periods sometimes, some months, and then have very heavy periods the next month potentially because of the buildup of the endometrial lining. Okay, so that's normal to be abnormal, right? A little bit is what you're saying.
Yes.
But you've referred to symptoms, all these like PMS-y symptoms, which are similar to what you get during perimenopause and then even menopause, the hot flashes and all these anxiety and, depression feelings. Are you saying that if you are metabolically less well, those symptoms are going to be worse?
Yes.
Okay. Wow. Wow. So that's big. So would you expect then someone who's going through menopause and now finally gets to their last period and or menstruation, and then now is like, okay, well, I don't know, do I need to go on to hormone replacement therapy or not? And it's based largely, often I find, on how bad their menopausal symptoms are. So it's like they get lots of hot flashes, they wake up sweating in the night, they're very anxious, they get very depressed, they're irritable, they all these kind of things, and the weight gain around the middle as well. So those people who experience more of that, we can then assume that they are struggling more metabolically, right? So they should it's more important that they do some interventions to improve their metabolism. And then hormone replacement therapy wise, how does that fit into it? Just out of interest.
Yeah, so there's a lot of really interesting thermoregulatory mechanisms, which is a fancy word for heat and temperature changes in a person's body that's regulated and managed by your brain. And there's certain nuclei in the brain that help mediate that. It's very much intimately related to estrogen and also insulin, of course.
Well,
And
yeah.
so when you go through low estrogen phases, that activates those thermoregulatory centers in, I think it's the preoptic nucleus of the brain, that changes what we call the candy neurons that lead to changes in hot flashes. Okay. And so that's why estrogen helps during that phase. And really, the main indication for hormone menopause replacement therapy during that phase is vasomotor symptoms or hot flashes. Okay, that's like the number one. It does help a lot with those other soft symptoms too, of like irritability and maybe some anxiety, difficulty with coping, energy, skin, all that stuff. It helps secondarily as well, but the main mechanism is through the brain, and so yeah. And then the other piece is the adipose tissue tends to secrete different adiponectins and inflammatory cytokines that are related to fatty tissue that also mediate that effect as well. And so that's why ladies who struggle with weight tend to have more hot flashes, because it interacts with that mechanism as well.
Wow.
And so it's kind of like a double-edged sword. It's like you're going to go through these hot flash moments anyway from just going through low estrogen phase of perimenopause and menopause, but then it gets really amplified depending on metabolic health and how your body's interacting with those inflammatory molecules.
Wow, that's absolutely fascinating. It gets quite complicated, but it's interesting how, you can't escape the whole obesity fat adipose tissue component, right? You think, okay, insulin, and then it's the adipose, and then there's estrogen. So there's a lot going on there, but I definitely hear what you're saying. And again, we can't ignore, maybe you don't have your period per se, but you definitely have to also look at the associated soft symptoms or the hot flashes as another potential vital sign for metabolic health. So then I know we're running out of time and we haven't touched on the most important thing, which is what can women do, Dr. Salcido? What are you implementing in your practice for these women who are struggling with abnormal uterine bleeding or perimenopausal, menopausal symptoms like we've been discussing? What do you do?
Yeah. So this is really important. And this is like the best part of what I do is to teach women what they can do on a practical level. So it doesn't feel like it's just something that's happening to them, right? And so really it's all about reducing that inflammation and and insulin level. And so for some people it manifests as inflammation, some people it's high insulin levels, but the treatment is the same. It's lowering your stress, sleeping well, and lowering that intake of carbohydrates. Okay. And that's kind of the magic bullet, which is way easier said than done. I'm a realist. Like, I have kids, like, we've got little parties that happen and stuff, and I know that it's a lifestyle change, not like an overnight band-aid, rip off the band-aid kind of thing, and so, you just do your best, but really if you can reduce those inflammatory factors, your body will heal over time. It's just going to take a little bit of time, but sometimes if you catch it early enough, then you won't even develop into any of these problems if you really understand the risk. And a lot of this has to do also with low vitamin D, and vitamin A and omegas and all these really cool things. And so I usually add a lot of these nutritional supplements called liver oil, all those kinds of things in the multimodal approach. Now, some people benefit from glucometers or continuous glucose monitors and stuff because they're very numbers driven. And so that helps with them understanding like what certain foods might be triggering them that they thought that their body could handle before. And so I deal a lot with the vegetarian population, and because I work at Loma Linda, was a large Seventh-day Adventist population who tends to lean more plant-based and grain-based, and so the addition of a continuous glucose monitor or a glucometer is very helpful because then they can see exactly what is causing certain glucose spikes, and that's a lot of fun to teach that. And so some people can handle it pretty well, some people can't. It's just depending on what that phenotypic or body habitus that's in front of them of me to figure out how can we proceed. So I do a lot of lifestyle discussion. I do a lot of how's your sleep, and do you like your husband? I know you love your husband, but do you like your husband? Like that kind of stuff. And so so it's not just one thing, but the other missing piece too, and I think that we forget, because I think that lowering insulin levels by reducing carbohydrates works so well. But the other missing piece is not exercise for like cardiovascular and calories in or calories out, but actual exercise for muscle building, because muscles are also, I think, the forgotten endocrine organ as well, is that muscles store glycogen. And so glycogen, of course, is the storage molecule for glucose. And if you can increase your muscle mass, particularly I think for people who are the slender folks, man, that is a depot for circulating glucose. And that's just one other place that you can store it. And so we know that, I really do talk about like weightlifting and stuff with women. And, like I hate exercising. I will be the first to say, like, I'm not a runner, like, but like, if I understand why I'm exercising, then like it feels a lot more legitimate, and there's like a real reason. So I'm like heavy on like lifting weights and stuff because that really helps me to like figure out, because I'm the slender person that I have higher glucose, so I have to put it somewhere. So I think that just looking at who's in front of you and what makes sense is really how the spirit of my practice. And I do have like a telehealth metabolic health practice if some folks are interested in figuring out really what my approach is. And I also have like that traditional practice at Loma Linda. So whatever people need, I feel like there's so much room to take care of women, and not just the traditional, here's your birth control pills or let's do your hysterectomy.
Wow. Well, we need more gynecologists like you, Dr. Salcido. Absolutely. I think the women in your care are lucky, but it shouldn't be lucky. All women should have gynecologists and medical doctors and allied healthcare professionals who are up to date and knowledgeable about these metabolic health aspects. And yes, you said obviously lowering carbohydrates is the quintessential intervention to lower insulin, right? But as you said, it's not everything. If you lower your carbohydrates, but you mentioned you sleep terribly, you do no physical activity, you are stressing completely, you're eating processed keto or low carb, so you're not getting all these nutrients you mentioned, like omega-3s, and and you're not getting enough sunlight, as you also mentioned, you're not getting your vitamin D3, then low carb can only do so much. Yes, it's going to lower your insulin, but are you truly ensuring optimal metabolic health? Are you reducing inflammation in the way you could be? So I love that you look at all these things, a very holistic way of looking at things, which is really, really important. And I also always love your humility and your relatability, because, you speak about how, you just do better, and you realize that we all live in the real world. And, you've got your, it just makes, I think it makes us all more able to listen to what you're saying, because you don't sound, I don't know, too far out to be able to relate to, you know what I mean? So I love that. I really love that.
Thank
So
you.
absolutely. Thank you. Everybody should be going to Dr. Salcido. And you say you do telehealth things, so that's great. It means that anywhere, you can be anywhere, and you can consult with you. And, you're just amazing. So thank you for joining us. I also want to say that if anyone wants to hear the lecture that you referred to about menstruation as a vital sign, they should please buy the women's health training from Nutrition Network, where you gave, that wasn't the only lecture. I don't remember what the other lecture was, but what was the other one?
There was a few other, when we talked about the menstrual cycle, I think there was one that we talked about fibroids. There was one that looks at the role of the microbiome with endometriosis. And Julio, on my YouTube channel, there is a mechanistic approach and discussion about endometriosis and leaky gut. And so check out my YouTube channel. There's a whole playlist of endometriosis videos that talk about that, being so close. I love that you brought that up. I mean, we could talk for an hours about endometriosis too, and that's another exciting topic. But the Nutrition Network has a tons of videos too, that I was able and blessed to and honored to be a part of. So check that out.
Yeah, absolutely. So I want to apologize for not calling on everyone who's been messaging, because I had a private chat open, not the comments section chat open. So I just want to do a call out to all of you who have been messaging. Geraldine from Maputo, that's awesome, watching from the UK. Wow. And Jane also saying it was so lovely to see us, and she really loves your approach, and she's thanking you for your for the support you offer to women. And Julio, always wonderful to see you. Julio wanted to explain a little bit more about the part about leaky gut, right? And that's the inflammatory stuff you alluded to now. Was there anything else you wanted to add there?
Yeah, we do really feel like the newer thoughts behind the mechanism of endometriosis is very intimately related to bacterial translocation, leaky gut, and how it basically, all those leakage of inflammatory cytokines and bacteria go down, down, down and leak to the uterus and cause a lot of that adhesive disease and sticking of endometrial cells to the lining of the peritoneal cavity, which is the pelvic cavity, leading to endometriosis. So that's really interesting stuff, and it's like one of my favorite topics too. So yes, that there's a lot of information about that out there.
Well, that's another whole talk, absolutely. And Nutrition Network has got a gut training in the pipeline, so hopefully we can find out a little bit more about that then. So just watch our social media pages to find out more about that. And also, like I said, if you want to become a Nutrition Network practitioner, then please do join the medical certification path. Applications are now open. So absolutely do that. join the Women's Health Nutrition Network training if you want to have more lectures from Dr. Salcido and find out more about women's health. And join Dr. Salcido at the World Nutrition Summit in Cape Town in October. Yeah, and thank you all for listening, for your comments, for everything. Dr. Salcido, what would you like to leave everyone with tonight? If you could say, I know that's a tricky one, hey, but maybe let's put it this way. If there's one message that you want clinicians and women to take away from your study, what would that message be?
Yes, thank you for the opportunity to say this, that irregular menstruation, problems with menstruation is not a female hormone problem. It is very much likely an insulin problem.
Thank you. Such an honor to chat to you. Thank you so much for giving us your valuable time. And I'm so glad you didn't get called away for another emergency surgery today. Yeah. Yay. But yeah, you enjoy the rest of your day, and we'll definitely connect with you again. Over and out, everyone.
Thank you.
Bye.